Good morning and welcome to our monthly webcast. I am Samir Mehta, your moderator today, and we have another exciting case for you. This makes it case number 20 and number 6 since our partnership with theheart.org. Hopefully you'll find another case of great educational value, and the way this works for people starting to watch us now is in a moment I'll take you to the cardiac cath lab where Dr. Samin Sharma and Dr. Kinney will take you through a most interesting case. Dr. Sharma will start with the didactic presentation which will teach you all the important things you need to learn about the case, and hopefully for the interventional fellows there will be some cues for you to benefit from also. So without any further ado, let me take you to the cath lab. Samin, good morning. Another interesting case in store for us, and before that I understand there is some recent excellent announcement about your hospital in the New York State Registry.
Yes, all right, thank you, and welcome to all our viewers and from our Mount Sinai Cath Lab with Anu on my left side and my fellows and rest of the staff. Clearly, as you mentioned, probably in the US, the only New York State systematically publishes the report of intervention as well as bypass surgery, physician-wise as well as hospitals, since 1994 for the PCI and since 1990 actually for the bypass. And year after year, Sinai overall has done extremely well in terms of ranking. Now what they do present basically, it used to be in-hospital mortality, again risk adjusted to the severity of the patient. Now they present 30-day risk-adjusted mortality and of all cases, elective cases, and the emergency cases. So the latest report came of the 2008. We are always 2 years behind because it takes about a 1 year more, additional 1 year after the academic year to have all the social security death index and so that in order to be complete, we always will be 2 years behind. Now the latest, if you start with our first slide, that this is the report of the 2008 PCI, and this is the top 10 volume centers in New York State, and basically having a risk-adjusted 30-day mortality and risk-adjusted mortality of the non-emergency cases, with Mount Sinai being 0.62, and second center is about 1,500 below with the Columbia Presbyterian. More importantly, and that is what I call it a grand slam, that Mount Sinai Hospital for the 3 year, they present 1 year and then 3 year combined. This is the 2006 to 2008 with the 13,742 cases, with all cases mortality being 0.63, with non-emergency cases 0.45 and emergency cases 1.78. Now what is emergency cases? Is all myocardial infarction. So 30-day mortality of MI in New York overall is about 3.1%. All cases taken. At Sinai it was 1.78. So the double star signifies statistically lower than statewide average mortality, and if you got single star, which is bad, that means the data that are bad, that you have a higher mortality. And clearly that since 1994, so far we have 15 reports, and Mount Sinai has received double star in 13 of them. The 2 are the one only we missed, but consecutively no other hospital ever in the New York State. And more importantly, that 3 year combined, that all in 3 categories of all cases, non-emergency cases and emergency cases, no center ever in New York received this double star notation. So that is basically the situation which we, of the grand slam. And this really goes back to the dedication, the hard work, and the protocol, what we have established in our cath lab, and of course the senior interventionalist. There are various factors into it, but clearly that it's a whole team approach and the protocol-driven lab which really has helped to get to this status year after year.
Samin, I want to congratulate you, Anu, your entire staff, the cardiac cath lab nurses, the technicians who work almost as hard. I always call them the unsung heroes, as well as the administration. 2 immediate questions which come to my mind. The volume from 2008 I see is about 4,500. How much is it now?
Yeah, it's actually the coronary intervention is about the same. because last year in 2010 about 4,700. Because what happened is that they combine all cases which had a PCI if they have within the hospital, or secondly, if we are out of New York State or did not have a social security number, those cannot be tracked. So in fact, if you take in 2008, Mount Sinai did about 4,970 PCI. But from the counting point of view, because all in hospital, 2 of them, if they will be combined as 1. And secondly, if they are out of state and there is no social security number, then that will be excluded. So that's basically.
What about the very large international patients you have?
Yeah, those basically they don't count in this. So that many centers which are very highly, in New York, I would say that every year probably will have about 200 patients international without social security, 200 to 300. Those will be missed, and that probably is true for any other center in New York.
Look, in these days of declining volumes, this is a stupendous volume. If I was to follow up on, I think, the next very important question, volume is one thing, but to keep the complications rate so low, if I was to ask you what are the 3 main reasons how you've been able to do that, what would you say?
I would say that starting with the lower and getting to the top, the one is the senior interventionalist always available, because clearly the lab, 5 of us, myself, Anu, Pedro Moreno, Krishnan and Kim, we do about 75% of intervention, 5 of us. But clearly the other 25%, some low volume operator, they get into trouble. So one senior interventionalist is always there, first. Second is the protocol. So that basically mostly through our interventional fellows, because they are the backbone of the program, so that working with any attending, whether senior or junior, that we have a common theme, common protocol, and which not only applies through the interventional fellow who are the key, our final delivery step, but before with the nurses, nurse practitioners and so that uniform driven protocol. And the third is the teamwork, that everybody right from the beginning patient comes in, everyone look into the patient issue rather than the number. And that's basically is the most important region, that everybody on the same page. Goal is, if sometimes actually nurse practitioner or nurse in the ambulatory area will tell this patient should not have a cath. And I can tell you the case was on Friday. A patient was referred, unstable angina, but they found a rising creatinine. Creatinine was 2.7 the day before when the doctor referred because unstable angina, and come to the hospital, it has a 3.7, hydrated became 3.9. Therefore, clearly that we did not do the case. And sure, we waited for 48, 72 hours, did it yesterday, and patient will be going home today. Because that case, if we would have had a PCI on Friday, would have been dialyzed today. So that's basically talking about everyone's involvement as a team under the myself and Anu's leadership, really driving 3 important regions to keep it number 1 all the time.
I think those are exactly right. Besides that, I think there is so much hard work, and you probably have 2 of the most talented interventional cardiologists right there in front of us. So take us, take us through the case. What do we have the plan for today?
Good. Anu, you start today's case.
Yeah, this is a 90-year-old female who actually presented from an outside hospital in December. She has been followed up by a private cardiologist for many years, and as you see, has had a bare metal stent to a right coronary artery in the late 90s. She was fine until Christmas Eve, when she started having chest pain and had a positive troponin up to 6. No EKG changes because of chest pain was transferred, and cardiac cath at that time had shown that she had a thrombotic restenosis of her bare metal right coronary artery and moderate left main, significant disease of her LAD diagonal system, as well as the moderate circ disease.
You go the old one here.
It's playing there?
Yeah.
You can see the angiogram that's playing. And that's the LAD diagonal bifurcation, near normal LV function, and this was a right coronary artery, subtotal thrombotic. And just a balloon PTCA was done. The question always comes, the big size vessel, should we have inserted another DES versus a bare metal stent? And there was some discussion at that time with the referring doctor, and since the results were very good, Just by cutting balloon PTCA, we just left it based on her age, just a balloon PTCA result. And she did well, was managed on medical therapy. This is her remainder of the system, left system, which is the left main and the circ disease.
And then now our goal is that today we'll show what we have and the intervention of the left main. Now you can show it today.
So, I mean, there are a couple of questions unrelated to the procedure which have come, which I think is important for me to point out. An interventional cardiologist from Central Florida is asking if the case can be viewed by his fellows. Of course, this is all archived. We do it within 48 to 72 hours. And in addition to that, all the questions which are posed by you, some of them I answer, some are placed there. So, yes, you can follow that. As well as you can also Twitter us on ccclivecases.com.
Okay, today the angiogram, if you see, this is her LV function. She has still has maybe minimal inferior or hypo, but overall preserved LV function. And this is a right coronary artery.
And that's a very interesting step, actually, what Anu did last in Christmas time on this. I probably would have gone and re-stented. But the question comes is if it is just a thrombus, many times we have seen your tight thrombus in acute MI, you did a angiojet and there is no lesion left. Should you still stent it or not stent it? That may be plaque sealing and so. But it was such a good angiographic result, I can't argue against not stenting further. But I personally would have stented even at that time, whether it's a bare metal or DES, because of large vessel size. Although the recent data of the basket prove again showed that even in large vessel, more than 3.5, DES still remains superior to bare metal stent. Of course, they did not include the patient with acute MI and maybe this nonagenarian, but overall, the message in the past used to be that maybe in the large vessel, BMS may be okay, but we have randomized trial to answer that question with the basket prove that DES still remain better because of largely lower subsequent restenosis, and lower subsequent restenosis translated into a slightly lower MI and mortality benefit, of course, lower TLR, that everybody knows. But the question was that can the large vessel still do better with the bare metal? Answer to that is no, particularly with the new generation stents of Zions and so.
And the left system today, you still have a distal left main. If you see in the cranial view, is moderate about 50%. But the most important is calcific prox LAD involving the diagonal. If you go with the Medina, will be 111 classification. There's a lesion before, after everything is after the diag, before the diag, and involving the diag.
Severe calcification and clearly significant disease at the ostium of the diagonal, but the distal left main doesn't look too bad, and even the how much are you quantifying the proximal LAD?
About, I think in the cranial view is still about 70%.
Okay, something concerns you there at the very proximal circumflex in that view, a little haziness?
Yes, there's haziness in the circ, and if you see here, though the cranial view, we could not appreciate the distal left main. Again, going back, always the question comes, which view is the best view for the distal left main? If you do not see it in the caudal, if it's an eccentric lesion, the next view where you nearly appreciate distal left main is always the AP cranial or RAO cranial.
I have actually started doing a lot of AP caudals, which I think also help. Samin, what are the teaching tips here? What do you want people to learn from approaching these cases?
Okay, therefore this by definition becomes double bifurcation. Left main going into LAD and circumflex, and then their LAD diagonal bifurcation. Now, this patient started with a syntax score of 40, but that was non-STEMI, and therefore we did a PCI. Now syntax score is 31, but still with the age, I would say our protocol that any patient with a syntax score 33 and above should go for bypass surgery will be different in this case, largely because of the age. And now there are two things: the issue, syntax point of view, and secondly, appropriateness criteria for coronary revascularization, which basically puts into three categories: the low risk, intermediate, and high, and where your patient fit in. Idea is, our goal should be that we are not doing an intervention in the eye, which is the red bar, inappropriate. Now this patient, based on the 2-vessel disease, actually 3 vessel, because there is still a RCA disease left, residual proximal, and the RPDA, and patient is on double medical therapy that is considered as a maximum medical, did not have any stress test. And what this criteria requires, that if you did not have a stress test, it is considered as low risk, that you have to assume if you did not have a stress test that does not come into equation, so it will follow onto the right side and becomes appropriate by that means. So that clearly appropriate, yes, maybe some cases maybe the equivocal, but most important is that you need to avoid being inappropriate. Now, just to say quickly that what we are going to do, because it's a double bifurcation case, I want to keep it this more time for the procedure, and particularly highlight a new recently introduced technique of the bifurcation. And the point again will be LV support for high-risk PCI, the plaque modification in this calcific lesion which you saw, bifurcation, and of course revascularization in the syntax, high syntax score patients which we have spoken. Clearly the patient with a high risk for LV assist device we need, patients who have bad LV and complex coronary anatomy. And we have 3 devices, balloon pump, PTVA and Impella. And Impella, basically the data recently presented, not in a scientific meeting, just by web, the PROTECT 2 trial, which supposed to randomize about 650 patients, high risk to balloon pump and PCI versus Impella and PCI. The patient ejection fraction has to be 30 or 35%. 654 patients, but trial was halted after about 400 cases, basically, and they presented the data of about half of them at 30-day. The Impella having a 38% event rate and balloon pump 43% with a p-value of 0.04. These are again preliminary interim analysis, but company decided, a Biomed, that because of the data, it seems to be that it's not going to show maybe additional benefit, so that the trial was halted. And more we will learn about the data in our ACC. Particularly issue occurred in the 12% of patients where they did a rotational atherectomy, rotablation, their very high event rate, largely because of CK. So clearly we need to understand where the device will fit in, so that in my algorithm, patients with the more than 35 EF, 20 to 35 or less than 20, the less than 20 I think still continues to have that a complex case, we need some support, Impella or PTVA, and Impella because of ease of use. Question comes, in medium risk cases, 20 to 35, I think the PROTECT 2 trial has shown that balloon pump and Impella both are okay, so that you don't need to go maybe in rare cases where there is a very high EDP or pulmonary pressure, but basically balloon pump does the enough job. Second, modification, we know rotational atherectomy like this lesion, so much calcific lesion, of course you need to worry about slow flow and perforation, but carefully we have done so many cases in our live webcast using rotational atherectomy with excellent results, and at time, couple it or just in a mild to moderate calcium, either with the cutting balloon flextome or by the angiosculpt balloon, works quite well in that situation. Then bifurcation lesion intervention. Last month we have whole talk on bifurcation with the various techniques, and most important issue remains is that 1 stent versus 2, that identify your patient which will need 2 stents beforehand, because every trial has shown anywhere from 25 to 30% of cases, even with a single stent technique, you will require 2 stents. So the goal should be not 1 stent or 2 stents are better. As I mentioned, that that's history. Goal should be identify which case will need 2 stents. So go forward, and that will give you the better long-term results. This is our analysis which we have published in a few papers, that you take a 1 and 2 stent technique. Seems to be that in the beginning, in the early part, we used to have negative results of 2 stent, but subsequently the 2 stent and 1 stent technique remained quite good. And in our precise SKS trial, actually we had a non-statistical decrease in event with the 2 stent technique without sacrificing stent thrombosis. Then question came, the latest publication yesterday in JACC about the DK crush. Now what is DK crush? It's called double kissing crush 2 technique, and basically that these are the 5 steps of this technique. That you put a wire into the both vessels, then you stent the side branch, that's a step number 1, and you then crush the stent in the side branch, that's step number 2. So you have balloon in the main vessel, you have crushed the stent in the side branch. Step 3 is for first kissing balloon inflation, that now you go with the high pressure. Now you recross the crushed stent of the side branch, dilate the ostium of this side branch, and you do a kissing balloon dilatation with the main vessel. Purpose here is the traditional crush technique, Achilles heel has been the ostium of the side branch, you can never open it. So now, before you go in, because you need to go to multiple layers and go to the stent struts of the main vessel, here is that this is actually proposed quite a bit by Chinese, our interventionalists, that really open the ostium with a high pressure, with a kissing balloon dilatation. Then your step number 4, now you put a stent in the main vessel and crush the side branch even further. So now step 4, followed by the final kissing inflation. That's step number 5. So the 2 kissing inflations. After the initial deployment of the side branch, and then of course after the deployment of the main vessel, and this is called double kissing crush technique. And this largely the results are driven by a better outcome and better lumen of the side branch. And what did it show? That in 370 patients randomized trial showed the first time in the literature, 2-stent technique, DK crush, showing the main vessel angiographic restenosis of 3.8 versus 9.7 with the conventional. Again, in conventional, in about 29% of cases, they required 2-stent approach. They need to put a stent in the side branch, which we know. But more importantly, look at the side branch restenosis, was 5% with the DK crush, which was 22% with the conventional. Again, 22 conventional is the similar data by ours and the other studies. Then the TVR overall from 14.6 went down to 6.5. Again, statistically superior in the DK crush MACE, and there was only price was paid with the stent thrombosis. That there were 5 cases of stent thrombosis in the DK crush, and while in the conventional group there were 2. So that clearly there was some issue of the non-significant stent thrombosis. But overall, first time this trial, and this actually, if you go back to our algorithm, which showed it last time, and showing that we have yet to have a positive trial showing 2 stents better than 1, even in a large side branch or complex bifurcation lesion. That is what our feeling has been, that those cases need 2 stents. Now the DK crush, first time, and this is actually my interview on the TCT MD and all description of this various technique. The key is that first time the 2-stent approach has shown to be superior. Then the final analysis, what does it all mean? Well, we need to duplicate the results. If other studies have shown, and we'll do the cases that if shows positive, then of course it will become maybe the preferred approach. And then lastly, syntax, which we all know, that 33 cases, that large number of those who are more than 33, we should send for surgery because of the lower event rate and revascularization, even with the left main. So having said that, with that note, we are just ready to engage this with the guiding catheter and start this particular case, and expect to do a DK crush maybe at the left main level.
Samin, take us, this is all very useful and extremely informative. The key is there are still some areas of overlap and haziness. How do you precisely apply the case to one of these techniques? You make a decision, let's assume you're teaching your fellows. How do you tell them? You take first the angiograms and then you go through the entire algorithm? No, I think very important. What we learn that and that is what goes with the most of the studies, that even if you have angiographically side branch remain 40+% angiographic, 40-50% angiographic lesion, you just walk away from it. As long as there is a TIMI-3 flow, or even 60-70%, as long as there is a TIMI-3 flow and the patient is not having any electrocardiographic changes. So that little haziness, and so because the paper which I showed last time, that FFR being done in many of these cases showed no difference, that almost 62% of cases had the FFR of more than 0.75, so that it's angiographic appearance rather than the truly the stenosis of the side branch. So that it's because of 2 stent, little haziness, little ostial side branch pinch is not unusual, and you can leave that as long as your plan was not to put 2 stents to begin with. Anu, 7 French catheter?
Yeah, we have a 7 French. Actually, we have a Voda catheter with the long sheath. I think we like to use the long sheath, except in this patient, she's probably a little short. It has almost reached the arch. Then it becomes negative, because your guide does not make the curve or doesn't getting into the vessel becomes a problem.
Samin, in the meantime, here is somebody putting cold water on all your efforts. There is a question coming from France. In fact, it's a statement. I would leave this patient alone. How do you answer to that?
Well, I mean, that's a very good, with the age, there is no question. But one thing for sure, that this patient, based on a double the anti-ischemic therapy, and still continues to have symptoms. She is very active. And the very important point that a referring physician for this patient here is in the control room, and clearly they felt that it's not the decision of just by our decision, but basically the decision that this is a significant disease and we should not just change based on the age. And this patient, they needed a revascularization. Now, the question here comes is that do you want to use a two-stent approach, or do you want to leave a left main? If it is insignificant by the IVUS, I understand. But there is no question to say here, proximal LED diagonal bifurcation is a significant lesion angiographically. We can do any test we want to answer, to confirm that. Because I would not be even surprised that IVUS may not even go with that calcium.
Samin, two other quick follow-up questions, again from outside the country. What is your age cutoff, if you have any, and what has been the oldest patient you took care of?
The very important point, age cutoff to us is no age cutoff as long as patient is mentally okay. The biggest cutoff is that if your mind is okay or not, we call it marbles, that they are intact, then there is no age cutoff. Second, that what is the oldest person? The angioplasty, we have done it in a 99-year-old, the few of them, but none of them in a 100-year-old. We have done 4 cases of a balloon valvuloplasty.
I had 103.
In valvuloplasty.
No.
Oh, actually, Anu has done one case. Apparently, she just said at 103. I remember that. Yes. And same, I had done one case, actually 104, which is in the, if you do oldest PCI case, I did 104-year-old in Jaipur in one of my hospital. So that there are patients, even with the 100+ years of age, will require intervention. Therefore, point here is that whether patient is limited by activity, can it do it not, and if the prognosis is limited, like in this particular case, would have had some other region, the CVA, COPD, and bad bound, yes, we would not have brought this patient back for intervention. But
well, age chronology sometimes can be misleading. A few weeks ago, I did a STEMI intervention on a 102-year-old. If you saw him, he looked in his 80s. Anu, a specific question for you has come. Which do you think is a bigger challenge, a vascular access or renal in elderly patients?
What do you mean renal? CRI?
CRI.
CRI. Yep. Yeah, I think it's a very interesting question. Both are very challenging at this age. Luckily, in this patient, we did not have a vascular problem, but both very important. I think one of the prognostic, what is a key success for the patients, elderly patients, when they present, when they are presenting to you as unstable, of the various comorbidities, 2 important factors that I pay attention, and one of the most important is your baseline creatinine. If your baseline creatinine is high, again you go with the EGFR. If it's less than 50, that's the time we pay a lot of attention to the dye, and the fellows know that every time they're being taught how to do intervention, what we call as a dye-less intervention. You do limited picture. You do a diagnostic with the 2 pictures of the left, 1 picture of the right, go to the LV, do the EDP, and that gives you an idea. If your EDP is normal, you can still do 2 cc LV gram. That will give you an idea what is your overall EF. So far, with these 3 pictures and 2 to 3 cc LV gram, you have probably done it less than 20 cc, and then you can make a decision how to intervene. And if your case is done between 60 to 70 cc of dye, and then we can be sure that patient will not go into renal failure. If they develop renal failure, that's when you start getting into trouble. And most of our rare mortalities, in-hospital mortality, is patients who develop renal failure and who develop the rare event of need for dialysis. And vascular is another important, is that if you don't have a vascular and for some reason we have still approached the groin two main things. If we could not, we can still do a closure when there is some vascular disease, the closure either with the external closure device or by using the star close. If we could not have done that and there is a hematoma, that's another reason why we end up with having any kind of complication.
Samin, they are not leaving you alone today. Here is an interesting question. How long did your 104-year-old patient avail the benefit of your PCI?
That's a very good, I had to say that only 9 months. Reason, he went to a temple, slip, hit his head, developed brain hemorrhage, and 2 weeks later died of that. So that's about 9 months and 2 weeks.
So it's a non-cardiac cause.
Yeah.
All right.
But well, hit his head, developed brain hemorrhage, whether because of Plavix, I don't know. But yes, let's go quickly.
Yeah.
Now we start this
Okay.
case now.
Yes, take us through,
Yes.
which is why we are here for. We'll leave the fate of the 104-year-old alone. I hear rotablator getting ready.
Yeah, so we have a 1.5 burr. As you see, we wired this with the rota wire. We have checked the speed about 155. Angiomax has been given. We have an ACT of 320.
Any concerns about bivalirudin in a 90-year-old, or that's standard management?
In fact, I think it will be more beneficial if we are thinking of either groin bleed or any kind of a bleed that try to use Angiomax.
Excellent. Any special tips in rotational atherectomy for the elderly, or you're just going with the routine and the calcification and the burr sizing is the same way?
I think burr sizing is the same way. We could have gone with 175 burr based on since the lesion is very long and we have to go through the left main, we opted 1.5 and same. Once you reach there, you just lose your knob here, move backward forward, so this will release the tension between the Teflon sheath and the burr. And next is at your Y connector, again you release your Y connector, movement backward forward, you see it, the burr is moving in the left main, that releases the tension between the burr and the wire, and the last would be on the dyna, tap, very slow movement. And now we are ready. You take your left hand, hold the guide and start burring. Slow pecking movement. Every time you keep going a little bit forward. And with your left eye, you are watching the EKG as well as your blood pressure.
Now tell us the pacemaker, particularly the left, our teaching is usually don't use a pacemaker on the left system.
Yeah, if you have a left dominant, the circumflex dominant or a right coronary artery, that's the only time we would use. But since she's an elderly lady and likely to have some conduction defects, we did use a pacemaker in this situation.
And also in the left main. We have seen some patients with the left main, when we are working it will develop asystole. So that if we are trying to go through the left main, then on those cases, yes. Yeah.
Anu, so you started burring in the distal left main?
Yes.
Yes.
Which would mandate that you will stent it?
No?
Not really. I mean, as long as I think if you have burred it and even if you have to balloon it.
Yeah. So I think that basically the purpose there is that you are just ablated maybe a little bit of calcium if you want to do a little balloon, because we are still not sure about the left main as your question you saw. Now on angiogram, back in the December, we were quite concerned about the left main, but today, definitely maybe with the better, it's not uncommon at the time of acute presentation that you see a restriction and constriction of the vessels, and they do get better when patient comes back later on.
So you would not necessarily, if you have done rotablation through a site, necessarily stent?
Yes, but if we do a balloon, that area we definitely will put a stent, yes.
And you've never had any major issues as a follow-up of these patients?
No problem with that.
Excellent.
And just to coming back to the point that this patient, we actually confirmed with our the patient's primary cardiologist that patient is still symptomatic and not able to do what's supposed to do, and that was one of the reason that this was patient brought back. But clearly that I would say that our philosophy always have been that how patients have been doing. If they are doing fine on medical therapy, there is no reason to do an intervention. We know that except in some situation, it really does not help. Now, the issue remains that once you have the left main disease, that that something should be done if truly the left main, and that is what clearly the feeling was. Maybe that was driven part of the patient's symptoms, that once you have the left main, there is no role of medical therapy. If we can diagnose that there is a left main, yes or no, and if the left main is there, that patient belongs to the intervention or cabbage based on their syntax score. But if there is no left main, then of course the medical approach is completely fine. Now, also as you saw that in the appropriateness criteria, they did give a lot of credence and importance to the proximal LED. Although the proximal LED trials all have shown that no difference in the DES versus with the cabbage, the Lima 2 LED, or actually the MAS trial, even with the medical therapy. But still, because of the common word being used as a widow maker, the proximal LED has been considered as a significant lesion or a contributing factor, that even if you don't have a stress test, you are not on medical therapy, but if you have a significant obstructive lesion in the proximal LED, revascularization is A, which is appropriate based on the data. Whether one technique is better than other, it always remains, because all the MAS 1, MAS 2 trial and guys with the proximal LED have shown that the cabbage comes on the top, followed by the PCI and then medical therapy. Okay, now Anu, tell us what is your next step now?
No, the next step is how we are going to plan the bifurcation. So if we are planning to stent across in the LED, then we have to go with a cutting balloon for the diag.
Yes. Okay, let's open the LED first. Let's go.
So what wires have you placed there, Anu?
So we have a run through in the LED, and I'm just taking out the rotor wire because that would otherwise make 3 wires. And then we have a fielder in the diagonal.
Yeah, therefore now question still remains that you may need some adjunct, because it's a 1.5 bar. Probably 1.75 may have been a little easy, better in terms of decalcifying. But again, we learned that it's just the taking away the superficial calcium, because your ultimate lumen dilatation will be done with a high pressure or maybe with the flextome or angiosculpt and followed by stenting. So that don't have to be real hero in terms of the large burr size, as long as we have removed that calcium from the top. So that this is...
So this is your 8 atmosphere test which you routinely talk about?
That's it. What
so
is
this is
how high are you now?
2520, which is a compliant balloon. Yeah.
Oh, compliant?
Non-compliant.
Yeah. Okay. This is the 8 atmosphere, open nicely. But this is the second area. We'll go to the proximal. And the question will come that do we commit for the left main or not? And I think I'm not ready for commitment of the left main yet. Therefore, we just go to now the proximal LED. And again, at 8 atmosphere, open nicely. So clearly that this is fine. You need to go to a next bigger burr. And here we are going to do 2 things. That after this, we'll bring back, do a cutting balloon of the diagonal, and then do the IVUS.
So, I mean, nothing wrong in some physicians being a little conservative in a 90-year-old and doing it just with maybe balloon, angiosculpt, and then stenting?
Yep, that's fine.
That could be.
Yeah, 2.5 or 6 millimeter.
Anu, another very interesting question for you. What do you use for sedation in a 90-year-old in the cath lab?
Yeah, I think we could ask that to our master nurse here, Vicky. Sedation would be the same, Versed, and we use morphine for pain. Now, in the elderly patients, you got to be very careful. When I say elderly, anybody above 75, especially above 80, sometimes you give 1. We start with 1 cc, and if they don't fall asleep or they start behaving a little abnormal, then we are careful and we use Haldol, anywhere between 1 to 5 cc of Haldol. Right, Vicky?
1 to 5 milligram?
How much? How many milligram? How many? So she's got 2 of Versed, 2.5 of Haldol, and patient actually is snoring.
That's a good sedation. It's a mini anesthesia.
So that's a cutting balloon now you have?
Yeah. We have a 2.5.
Okay.
This question comes up repeatedly on our the follow-up. When do you use a cutting balloon? When do you use angiosculpt? And so I would say the same. These both devices are okay for the ostial lesions and mild to moderate calcium. But if you have the calcium, like in this patient, the proximal LED at the both edges, come back and go back in again.
I am also finding the angiosculpt very good for instant.
Right. And therefore, the patient with the instant restenosis or very uncompliant lesion where you need to go to high pressure, you use angiosculpt in that situation. And the third will be that the long side branch lesion. Like in this case, there is just an ostial lesion. So if it's the long lesion of the side branch, we would have gone with the angiosculpt.
Looks good.
Yeah. Look at this. Good. Take this out.
Still may be a problem.
Huh?
If you're going
Probably
to
stent across.
Distal. The looped.
Which will work? Oh, you mean will straighten? You want to straighten out the loop now? Go. Yeah. Straighten out the loop.
Now, another important point here, if you see that my fielder wire has looped. So I have to straighten it if you are going to leave the wire in the side branch.
Good.
So you take the balloon all the way and just pull back the wire and take out the loop.
Yeah. And clearly that, you know, the leaving the wire, which is a routine practice, jail side branch in this bifurcation lesions, there are a lot of issues. Some people actually say that you can leave the wire and some, but don't do the PCI because just if you create some dissection, that will definitely require
IVUS, no?
IVUS.
So, I mean, this wire had looped. What if a wire is just gently doubled up? Would you insist on straightening that, or that you can leave alone?
Yeah, doubled up also because no, if you are jailing it, otherwise it's no problem. No means even looped wire, once you're pulling it, no. But if you are jailing that, it's very, very important because only 2 cases of Mount Sinai, we probably had left the wire in the side branch maybe over 5,000-6,000 times in the 2 cases where the wire broke up. One when the wire wire doubled up, exactly what you said, and did not the interventionalist did not recognize, and they pulled and then wire broke off. The second, we can take the pacemaker out. And the second was the case where the loop, that it was in a small branch loop, and then we could not take it out completely.
Okay.
And those are the only 2 cases. Now we are with the IVUS here.
Okay, start.
So what would be your, what are you looking for the IVUS here? For sizing or distal left main?
Distal left main.
Okay.
Just
A lot of chest pain.
Excellent.
yeah, now should be okay. Yeah.
In the proximal LED there or where? Okay.
Yeah.
Looks to be around
We are
the
in
diagonal.
just at the level of the septal.
Right.
Lot of plaque is still.
And
now,
some calcification.
Yeah.
Some.
This is
Right
the
there. Looks like the calcium has been interrupted now by our rotor bar.
Bigger vessel than what it seemed, which is exactly what Gus Pichard says.
Yeah.
And this is the distal left main. Bookmark there.
So I would favor leaving it alone, no?
Okay. Let's see, because our Excel criteria is also that if your lumen is about 6, if you're 6, you can leave it. If less than 6, significant, you need to diagnose maybe in some cases you can do FFR to say if it is significant or not. But if it is less than, more than 6, or some people actually will say even 5.5, left main can be left alone. Therefore now they will do the analysis.
So, I mean, question from down under, any age cutoff for a drug-eluting stent?
No, I would say no. What basically has been that there are a lot of papers in terms of even octogenarian, higher benefit. Of course, there is an issue in terms of the bleeding.
B3.
So that part still remains clearly.
Any concerns about their ability to take dual antiplatelet therapy?
I would say that now, knowing that in many of them, we just give it for 6 months because enough data from the Giants v USA of 5,000 patients, many of them, about 16-18%, that given 6 months and after 6 months there was no stent thrombosis. So that we have cut down the time period. Longer you are on dual antiplatelet therapy, higher will be the chance that the patient will have a bleeding. So that if you cut down to 6 months, maybe at in these cases, so the bleeding or some other kind of non-emergent surgery occurs at follow-up, that those patients should get that you will be able to stop particularly the clopidogrel in these cases because they will not be on FEN. Yeah.
Anu, what's the verdict on the left main?
Yeah, you can see it, 5.1.
So you are going to?
I mean, it's a quite significant. Angiographically, also, in few views, actually it looked quite significant. And let's take this one picture.
Why you want this?
I look in, it looks more for left main. Yeah. Yeah. Because there, the whole area will look roughed up, particularly because of the ostial. There is a lesion in the ostial LAD, there is a lesion in the ostial circumflex, and if you want to take care of it, you need to go to the mid-left main. Though in this case, ostium of the left main seems to be quite fine, right, when you pull back, and it's the distal to mid-left main, and if you want to deal with this clearly, methodically, I think for the LAD will be okay to have a one stent approach, and because diagonal opened up very nicely, and but the left main we need to take care. By question is by what technique we can decide. Now here, look at the circumflex.
Yes, which is what my initial observation was when...
With the caudal picture.
It was always there about very hazy 90% circumflex and so. So with that note, I think we clearly that if you want to take care, if anybody says that, you know what, I want to take care of the circ only, I will miss the left main, don't want to do with the distal left main, I can tell you that's a wrong approach. The two reasons. One, that you will be try to be overcautious that you will miss the ostium of the circ. Second, once you have a distal left main disease, it's better that you just cover the distal left main and then kissing balloon dilatation through it, or maybe two stent approach.
Okay, 11 minutes, do what you want. Let's see.
Okay. So now we are taking care of the LAD first.
Yeah, we have a 3 or 28 Zions going into the LAD.
Yeah, because of the good vessel size, we are leaving the wire into the diagonal, and we with the 3 or 28 Zions. You go to same view, 1 and 30. Good. That area probably not dilated at the ostial distal left main. And pull the wire back.
Wire back?
Yeah, to pull back. Now, since we are committed for the left main, let's dilate that ostial. Look at this ostial LAD is quite significant with the distal left main. And
you want a 3O high pressure balloon?
No. Yeah, you use the same
five?
balloon will be okay. Yeah. We'll go with the same 2.520 balloon which we had earlier.
You pulled everything out.
Okay.
Nonsense of yours.
So, I mean, another very interesting question. Have you ever broken the traditional rule probably for a STEMI for cutoff or prasugrel for 75-year-olds?
Yes. Actually, no. I had broken the rule of 75, or even with the CVA, take the new wire, new filter wire, if you want to. Or you want to no wire now? You want to leave the wire out? Okay. Yeah. 1 second.
No, it's badly.
Yeah, good.
No,
Leave it.
diag is bad dissection with a cutting balloon.
You planning to put a wire in the circ?
No.
Okay.
Right now with the diagonal only. So now you want to take care of the diagonal a little more first? Huh?
It looks
You want to
bad.
take a picture again?
Yeah, it's very bad.
Yeah. Again recoil. Look at that. Of the diagonal.
So, let's say if you had done a rotational atherectomy of the diagonal, how do you think that would be looking now?
Yeah, I would say that this recoil would not have been, so that we go back and dilate the diagonal. You just use this. Yeah. So I think diagonal has to be taken care.
At this stage, you don't favor a two-stent strategy?
Well, I mean, the only thing is will be the two stents here, and then maybe the two stents in the circ and so that if need to be, let me just dilate once again. It was a focal, and I felt that once we have a good dilatation, that this plaque prolapse actually should be less with the flextome, but surprisingly, although these ostial lesions are very tricky.
Also, with the IVUS just around when Anu was pulling back, there was a suggestion of fair amount of calcification at that ostial site too.
Right. Get a new filter wire, and you want to get a new wire.
Take a deep breath, dear.
Okay, wire more.
It's too long.
Okay, give us a new 2.5 15
Regular balloon is okay.
Huh?
Why?
No, you need a little high pressure.
Oh.
Yeah, NC Voyager.
But
Yeah.
that then you'll end up stenting.
Yeah. You want to change the wire, or wire? We are okay with the wire?
I'll change it.
Huh?
You have to be in the main vessel.
Okay. Yeah, this is the same thing. The key of the bifurcation, as I say all the time, is the side branch. And this is the whole case, that how we come up with the good results of this side branch. Take that other wire out, I would say.
Trying to get it into the main branch there.
Yeah, yeah.
Yeah. This one, let's take the old wire out. Good.
These, I just hope that our viewers find these small minor things. These are extremely important, to initially it looked the diagonal was okay. Now you need to fix the diagonal. So let's optimize the wire and don't take shortcuts, put in a new wire there and give yourself much better. There you go. That looks to be much better.
Main lumen, yes.
Likes to double up there. So what would you do for the diagonal now?
Yeah,
no,
now-
we are just going with a high pressure balloon
Okay.
to make sure we have a good ostial, the ostium has recoiled. Now, you saw how we wired the side branch without use of any die. So we kept the previous wire there that will give you as a railroad. So you don't have to keep using die to get into the side branch again.
All excellent points, Anu. Having watched 20 of these sessions up close, I have always appreciated how miserly you are, and so appropriately so, with the use of die. Die is not our friend, and
Not anymore.
Yeah.
Good.
Yep. And I know that everybody is like, let's see. We don't say see. Even fellows want to see.
That's also, I think, a factor of expertise and doing it. I
Leave
think.
for a little while.
Yeah. So now basically what we do is that once you're getting a good, goal is to get a good balloon result. So that's our old balloon technique, that you crack the lesion. This is 2.5, 15, yeah, the quantum apex actually. And then they leave it at half for about 90 seconds. The goal there is that you cracked up the plaque, with leaving a moderate pressure, you tack up those dissections. And
Do you want to dilate the LED now?
with the same. We'll dilate with the same.
Or not?
Yeah.
Yeah, I actually use that technique for stent deployment, where I use a double inflation. The first one is to expand the lesion, and the second is to oppose the struts.
Yeah. Good. Take a picture. And then we'll dilate the ostium later.
Okay.
I think we'll be okay. Go to the ostium.
Little dissection
Yeah,
there
which
at
is
the superior
expected.
end.
Yeah.
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 But excellent flow.
Yeah. Good.
You get a follow up on these patients, and some of these heal so beautifully.
Yeah. Absolutely.
Good. Done.
Good. And clearly that, remember the original PTCA paper by Hartzler was that if you have a dissection, that of course it caused with the higher acute occlusion in hospital in 30 days. But on the long term, the dissection translated in the PTCA with a lower restenosis. Reason being is that those are the cases you probably took care of the plaque. And compared to the many times with the PTCA, we just do a dilate the lumen, and it recoils very quickly. So that presence of type A and B dissection, in my opinion, maybe even a small c is of NHLBI, is a favorite for restenosis, although you need to be concerned about the acute thrombosis, but acute occlusion in next 24, 48 hours. Now, with the current standards of the dual antiplatelet therapy, I would say that acute occlusion does not take place, and we have seen that, that unless you leave a extensive dissection, then only you have this problem.
Glad you mentioned pioneers like Jeffrey Hotzler, who really taught us so much and put us on to where we are today. Is that a stent you have now?
Yeah.
Yes. It's still not making the turn into the LED.
Right.
I think why don't we go with the 3O high pressure?
Okay, give us a 3O high pressure.
3O20 high pressure.
So you think it is getting hung up on some calcified plaque? At the distal left
calcified
main?
specule, something
which
there.
is, it was fairly impressive on the IVUS. So let's. I think the high pressure balloon would take care of it. But if not, would you, in some of these situations, once again go back, maybe even with the
in this situation, I think a high pressure balloon will not take care of it. Yeah.
And
if we have never cracked the lesion, that's the time you may have to think about going back with rotational
Right, but
atherectomy.
you had clearly even started, which is at what point I had noted the ablation had started in the distal left main. So I think you're right.
Yeah, and in those cases, maybe that will be the ideal case that if you cannot get maybe the wire crisscrossing.
No, there's no crisscrossing.
This is the new. Okay, good.
No crisscrossing.
Yeah,
There you go.
Yeah, that in those cases that you can angiosculpt may come handy that you need to go to high pressure. So here we have gone. It's a 3O20. Now I'm at 14.
Okay.
You go 18.
18.
What balloon is this?
This is a 3O20
NC Voyager.
Okay.
compliant.
Non-compliant.
Non-compliant.
Yeah. Keep saying compliant.
And do a little
Okay,
distal
no.
left main.
There's something there.
Yeah.
Go up.
Yeah. Yeah, there is a mid left main to distal left main. There is still a quite bit of plaque which we have gone to 20 atmosphere.
Often happens in a complex case, the plans change as you notice more and persist with it with all the deliberation and care.
Yeah. No, I think that I would say that probably what happened is here
Go quickly.
we underestimated the distal left main and ostial LED disease, which on the IVUS became very clear that it's a very calcific chunk.
Okay, yeah.
And 1.5 bar
ready.
did okay, but it did not do the complete job, and it went through the distal left main without any problem, but without maybe decalcifying that the plaque.
We have to move on. She's becoming restless now.
But patient does become very symptomatic, rightly so, with that LED intervention, with the pain, little bit of EKG changes. And see the fluoro wire.
Well, also maybe you need to pull back the guide a little bit.
Yeah.
Okay.
Stand. Good.
So what do you have there now?
Now we have our stent. We're going
Same
back.
3028. The stent, once you bring the stent out, you always look at it that it's not flared at the corners, coming out and
so
getting
the
into the guide.
Plan is to use a single long stent across
But 28, no, across the diagonal, but you still need another stent for the left mains. I mean, that still will need a separate.
Same area where it was getting hung up before.
Okay, give us another wire fielder.
Okay, another filter wire or Grand Slam.
No.
Okay.
Take a deep breath, dear.
No. Okay, get a filter. Yeah.
Another deep breath.
And breathe normally. Okay, what we'll do is now in this situation, pull back the stent into good. Now put a wire into the diagonal wire also into the LED. Let's use this buddy wire.
Let me
quickly.
close it. It's not going
Go.
to go on that one.
Yeah, go. Just try. Because I just want to make sure that it's not a crisscrossing which is causing it. Because many times, if the wire crisscrossing is going to cause the problem.
Balloon would have gone.
Huh?
No, give the other. We'll go on the.
You mean idea is that use more floppy.
Yeah.
We are going to use, clearly that stiff wires in the calcific angulation sometimes works against us. Therefore, what Anu wants to do is.
Now the question about crisscross, if crisscross was true, then the balloon would not have made the turn first time.
So now you're
Yeah,
going to
we're
put
just trying to go with the fielder wire in the LED.
Okay, so more
So you'll have
support,
the
buddy wire, and
yeah, and see if it will go.
Samin, I've been very impressed watching a lot of PCI in the Far East, in Japan, China, where their threshold for putting 2-3 wires is extremely low.
Yeah, right. That's true. Serial diary, okay. Yeah, always will happen that particularly the hydrophilic wire may go through subintimal, so have to be very careful.
And there was a significant lesion just about there.
Yeah. Will die.
Deep breath often helps, which is not, this is a problem with the too much sedation also.
Excellent job with the wire there. Seem to be going into every branch the patient has.
Okay. Now the same, the stent, recrimp, go. Because I always advise that once your stent has come out, make sure you recrimp at the edges. Because not uncommon, you are coming into the guide catheter, it's a small strut has been lifted, and that will may create a problem going back in or even dislodging the stent. So the recrimping, the stent which have been withdrawn is very, very important. Wow.
Maybe go with a smaller.
Very humbling.
Yes. Okay, get us a 3-0 angiosculpt.
Angiosculpt, or do we do with the shorter stent? Why don't you go with the short stent? This is, I think it's too long, not making that turn into that calcium.
I would go with angiosculpt. Yeah, let me quickly come in now. 1 second. Yeah. Yeah. Okay, now what we do, I think we need basically that area probably need to dilate a little more. So that we take this one wire out.
Which wire you took?
We have taken our
Grand slam?
No, not grand
run
slam.
through? No,
Yeah, run
the
through.
out.
We have taken
Why?
the run through wire out, and now only my question still remain is that
You should have
Good.
left it.
Yep.
Okay, more support with
Yeah.
the wire there, repositioning.
Yeah.
Now you're back
Okay.
with the
Now ask her to
angiosculpt,
do
or
the
what
deep
are
breath.
you?
Now take a deep breath in for me. Deep breath in. Deep breath in. Good job.
I think we need to breathe normally.
Okay, breathe normally.
No.
We have to,
You lose
otherwise-
everything.
Yeah, I know. Need
Why
to
do you
be-
take out the Grand Slam?
Huh?
Why do you take out the, not Grand Slam, why do you take out the run through?
So now you think with 2 wires down the LED and
Yeah,
taking
although
it
we
from
had
the
a 2
diagonal.
wires earlier.
Yeah, no,
My
but
only
taking
question
it from
is,
the
yeah,
diagonal, you may
right.
be able to.
Okay. Looks like no.
So plan A, B, C, and D have not
Right.
worked.
Yes.
All
And
right.
now we go to further, and with that same thing that the idea remains is such a calcific that do you needed a little bigger bar, 1.75, so that if that why we are having this struggling is that probably with a 1.5 bar it did not do the enough job. Now then when you are using this, I think we can go back your wire into the diagonal. There is no reason for us to, although this may not go.
You'll have to be extremely careful. There may
Yeah.
have been some intimal disruption at the ostium.
Yep.
And it's looking a little hazy there.
Again. Yeah. We'll just put a little torquer, guys. And then- Yes, sometimes in these tortuous and vessels, usually we don't use the torquer, but may require in some of cases. And as pointed out, that you have to be very careful because we'll have very easy to go subintimal. And if there is a difficulty, you can leave that, then you can go through the stent struts later on, because rather than creating a dissection beforehand. Huh?
Yeah, that would be my thought,
Yeah.
probably too. As it is, I think having just a single wire in the
Yeah.
LED,
So
you
let's
have a
see.
better
Let's
option.
dilate first. Let's see now. If angiosculpt.
It's not going to go.
Yeah. Okay. So let's get the Grand Slam, the high stiff wire. Because I think we'd need a little more stiffer wire in this case. The floppy wire did not work, and many of them. Okay. We have the Grand Slam wire.
Let me wire the diag. We'll lose the diag otherwise.
You made the curve, right?
Why are you
Yeah.
rushing now?
Yeah. Let's make sure the tip is clear of the diagonal. Okay, now we go with the 3O high pressure once again with this Grand Slam. Because Grand Slam, again, will not be that easy, one-to-one torque compared to our other wires, but have to be a little careful. Now, we can change many times.
Where's your thing? No.
Torquer, yeah. Okay. Let's get the high pressure now. I think we just need to get on this stiff wire high pressure balloon. This is the 3O. Okay. Now patient is doing okay, Vicky? Good. Now what I'm going to do, usually that is our strategy, that it works better on the more floppy wire in this calcific angulated, but again, in some cases they work a little differently or behave differently, like in this particular case. Good. And I think we can start
no,
opening it.
no.
Okay.
Go inside. Now don't cause all problems here.
Good. Now,
More.
yeah.
It's not going.
Same thing,
Let's
it's a
go
huge
with
balloon.
the,
Yeah. Okay, one sec. Let's get a maybe 3.5, 12 or 15 high pressure balloon, the new one. Yeah, because I think 15. Yeah, 15
and
is
let's
good.
take a short stent.
Samin, would you
Let's
consider,
dilate.
let's say, a short balloon, a 2.5
Yeah,
balloon?
that's what we are doing now, 3.5, because this is a used balloon. Not uncommon, once you have done this used balloon in difficult cases, that did not work, so that we are using with the 15 now, and little bigger size, 3.5, what is quantum apex actually. We actually have, to avoid duplication, each sizes we have of one variety only, whether it's a quantum apex or NC Voyager and so on and so forth, so that this is what we are now. And let's
Get us
dilate a little. Yeah.
3.23.
Yeah.
Let's make sure diag or LED is not
Yeah,
close.
yeah, yeah.
LED is close.
I could not see the ostium, but the flow is good in the diagonal at
It's
least.
so far okay. I mean, it's not great, but so far okay. And patient getting little restless and some EKG changes. So what I'm going to do, and this is what is the same principle of many of these stiff wires, that I'm going back on the our fielder, because the Grand Slam was there good for support, but it's not good for advancing.
Get us a 2.5 balloon. You have the 2.5?
Yeah,
Okay,
good. Go up.
Okay, you did
Let's
go
make
across.
sure is there flow or
Yeah,
not.
yeah, good. Go up now.
Get us a 3.0. 3.018 stand first.
Okay.
20
Yeah, therefore,
years.
clearly that that AK feels that now maybe we should go with a short stent first. Yeah, go up again.
Yeah, I think it is this area which is
Yeah.
causing the problem.
Good.
Should not have taken that. Diag will be gone now.
Yeah. But at this time, we keep the LED first. And clearly that, question comes is, which is Anu's point, very important. Go up again. We worry about the diagonal, but in this particular case now, I think first we need to establish our LED, and once the LED is done, then we'll think about the diagonal. We can always go through the stent struts of the diagonal. Good.
Can we make sure the flow is okay?
But right now we may not be able to do anything. Hold. Get the stent. Yeah.
Should we?
Yeah, but let's get a first stent into the LED. Now we are going with the 3018. Establish the LED. Clearly that focus here, that don't worry about the diagonal at this time in this difficult situation, which we didn't expect to begin with, but these things will happen. The now goal should be that we need to be the ready, and somehow this case, no matter what we do, this is a 3018. Vicky, ask the deep breath. Okay.
Good.
Now.
Go. They're not going in.
No. It is that chunk at the level of the diagonal. We know the diagonal may be a little compromised at this time.
No guideliner. No.
And breathe normally. Yeah, there. This is just amazing. I mean, would not
No, that is
expect
because
it.
we never went down there with the balloon.
No, we did. We dilated that area with the balloon.
Not that down.
Huh?
Not there. Further down.
So let's
Go
dilate
with
once again.
Okay. Go with the balloon now. Oh, this is 228. This is the.
Yeah. Now, I
What
just want to
balloon is-
try
No, no,
once
no.
again on the Grand Slam. Let's hold it one second.
Grand Slam is not going to go.
Huh? The
Get
get
a-
that
get a
3.5, that same balloon which we had, we need to dilate there. Okay. Now the principle which we always say, once your body wire go on the floppy, we are come to the test here, that whether which one will be better, and looks like there is no answer to it. That the principle still remains the same, that you need to do it on the floppy rather than on the stiff wire.
Okay.
So this is, we are back again. We are
Okay.
going to go back again and dilate. Now EKG and blood pressure is okay, although I'm sure patient is moaning that having some chest pain.
You want to use the guideliner?
Yeah, let's get the guideliner. The other question is, what else can you use for the distal that want to get guideliner ready? Another device of the vascular solution that get you that to the delivery of your devices. Go up here.
See, there we did not go up.
Okay.
You
Go.
know, exactly. That's what I was going to mention. Even
Go.
there is a
Go.
significant.
Negative.
Down.
This is the 3.5.
3.5. So we tried here, as you saw, the angiosculp earlier. Go up.
Okay, pull back again.
Yeah.
That angle.
And yeah, this is it. Now everything will go. 18,
No,
right?
No, 18 or 28 you want.
Yeah, good. No, now anything will go.
Well, you
getting
mentioned
oxygen or no?
Jeffrey Hotzler today. He should be very pleased to see balloons work
Yeah.
still.
There.
Yeah, 1 second. Yeah, go up here. Okay,
Okay,
negative. All right, we are going to try now our 18. I think we go with the 18 stent first, so that we want to get guaranteed. Good. Clearly, the deflated balloon has gone much easier, and I think that we underestimated the spicule of calcium, and that has been the issue. And now we go back in on the fielder wire. There is a Grand Slam side by side. I'm sorry we have gone beyond our time, but I think this is a kind of a case where a lot of the points that you just have to go step by step. There is no reason to cut short those. Let's see, 1 second.
So, I mean, to me, this is exactly the purpose of our doing the live webcast, is to show exactly every case is not going to be straightforward. You
Take
see
the
a
wire
live
out.
struggle,
No,
and
Yeah. Okay, then
Deep breath, dear.
deep breath.
Nice deep breath.
You want to use the guideliner now?
Yeah.
Okay, good. So let's use the guide liner. Now, additional support. How can we get that? That this is a new device of the vascular solution, which is the guide liner. It is a monorail, and you can see here. Which one?
You have to
Side
go on
branch?
both.
Okay.
So that's
Yeah.
put the torquer on that so that we know that's the Grand Slam. That is the Grand Slam.
Okay. That's the Grand Slam. Now you can put both the wires through the lumen of the guide liner. Good. Okay.
Got that?
Go.
You know, if the company Vascular Solution advertises, this is exactly the kind of a case they would like to show that this works. Let's see how.
That's what.
One,
We
how
get the
you
stent again.
No, you want to
place
try
it
the
exactly
28?
there and
Yeah.
how this should.
Yeah. And we go with the 28 now.
28.
Yeah. Let's go with the 28. And the guide liner basically is the monorail and giving you extra backup support. You can think about the guide in a guide.
Yeah, it's like putting in a 4 French guiding catheter through a 7. And
Only thing is this is a 6 French liner now.
yeah.
Yes.
But very flexible,
Yeah.
very soft tipped.
Look at this.
Excellent, just
Yes.
excellent demonstration.
Now I'm going to take out the
One of the wires.
yeah
Which one
yeah
did
yeah
you
that
remove?
was the one which was the,
The
Grand
Grand
Slam.
Slam.
So now what you can do is just pull this guide liner which you see here gently back so that you can see.
Should be such a wonderful demonstration of people and cath lab managers who insist in not keeping an entire range of new products available. I bet you nobody would have
Okay,
thought
go.
that this would be what would bail us in this case.
Ah.
You need to go a little further.
little more distally.
Yep.
and-
Yep. And we deal with the diagonal a little
Yeah,
later.
yeah.
Good.
You go for as distally as you want.
Good, right?
Yep.
Yeah, go.
Okay. This is a 3028.
Samin, you made a wonderful statement. I think it's important enough for me to repeat it because it was said in the middle of our struggling that at this moment, let's not worry about the diagonal. There is cases become more challenging as they go. Keep the objective clear. I have in all the years I have done angioplasty, I never lost a patient who had a small OMB or a diagonal. Let's focus on the main vessel, get that exactly right.
Get another fielder wire in case we need. Yeah. Pull back a little bit.
What stent do you have there?
This is a 3028 Zions.
Zions, okay.
Yeah.
Which should, if you need to go through the struts of this, that should not be too hard.
Okay.
Yep.
Down.
This is the same balloon of the stent.
Same balloon that we are doing for the distal left main.
Okay.
Vicky,
And-
little Neo.
Very intrigued
Then I
how
take out
the
this
circ
guideline.
is doing here.
Yeah. Yep. Yeah. Get ballooned out in the guide. Take it out. Good. Okay. Good. Now you remove your guide liners and so, and then we'll see. All right. EKG looking better.
The thing is, I don't know whether this one will come out now. Show me some fluoro.
Yeah.
Okay, good. Pull open that there. Yeah,
And the wire coming back.
Yeah, almost.
good.
Yes.
Okay, okay, okay.
Okay.
Anu, what was the
Insert this
difficulty? What was causing the challenge they're removing?
No, I had the balloon and the guide liner
Got it,
together.
got it.
I was
got it.
taking everything
Yeah,
out same
yeah,
time.
So I think first, the ideal would be that you take a guide liner first and then the balloon.
Exactly right.
No, we.
Stent
I
balloon.
mean,
Okay.
normally we leave the guide liner there,
Yeah.
but
Okay.
right now we don't.
All right. Let's see it to believe it, how things are, and then rest we can just do the patch-up case, what need to be based on the diagonal and circumflex. All right.
Well,
Okay.
Not unexpected what we are seeing. The circ is there. Distal left made the way it is. and then diagonal still remain the subtotal. Go through the diagonal struts. Now, only question is from webcast point of view, where do we end? Clearly, this case will require a little additional work. Do we continue another 5-10 minutes?
I think you should.
Go.
I think you should.
Open the diagonal
Even more if you have to.
Yeah. Okay, then we get a new balloon. You want to get a track? 2.515 track.
We just leave a PTC of the diagonal. Okay?
Yeah.
It's going to be very interesting to see how you navigate the diagonal now.
Yes.
So what would be your preferred wire to go through the struts at this moment? And that's
It's a fielder or whisper, one of the two.
All right.
Has to be the glide wires.
Okay.
Same. Now see it's
You're not through the struts there. You're
The rare cases we actually have gone the Boston Scientific
choice PT.
choice PT and they
we may need a balloon support.
Yeah, balloon supporter. You want torquer? You need a balloon?
Connect the balloon. Yeah.
Okay, take the balloon. Yeah.
What balloon you have?
What is the track?
2 or 2.5?
2.5. 2.5
Will
will
not
go.
go.
2.5 will go. Yeah. The Boston Scientific wire which we yeah. Huh? Kinetics. Kinetics, which is also very sometimes quite helpful in this situation.
You could
The wire and the LED.
also put the guideliner also here, no? I mean, if it's probably an overkill, but
See, one of the side back of the guideliner is your pressure goes very low.
yeah, I even noticed that. I think that's when the patient
and
wasn't
in this kind of
tolerating.
situation, that's why I had to take it out. I mean,
Right.
when if
Exactly
the patient is stable, you're okay. If the patient is unstable or borderline, you cannot use that.
Yeah,
Once you're done your job, you got to take it out.
Okay.
Let's
Right
see
at that
will the type
dissection.
Will it die?
No.
Prepare that.
See, other thing is a long balloon could be against us. We need a small one.
You have 6 or 9 over the wire. We can use that.
No, not over the wire.
Which is fine.
Don't think you are in the diagonal there, are you?
Yeah.
Okay,
But
some
question in the true lumen versus
Yeah.
subintimal. That's the key.
You know, often even one of these balloon catheters will work against you there, but let's looks.
Bring the balloon up to the ostium of the diagonal and let's see if we can move a little bit further. Yeah, good. Now here, wire in different direction. No,
Maybe in the branch.
yeah. It's not branch. It's subintimal going into the top lower branch only. Okay, let's put a LED wire a little further.
Excellent job. Fantastic.
Yeah, do Fogarty. Good.
So this is a very important now, just to make sure
Absolutely.
that we are in the true lumen.
Yep.
Go back forth, Fogarty.
No doubt you are in a true lumen. Excellent job.
Dilate.
It's a wonderful job with the wire, worth staying on and going beyond our time.
Yeah,
Go back.
good. This is the 2.5, 15 track.
Yeah.
Yeah, and we are dilating the ostium now.
And here you truly have to wait now couple
Few
of
seconds.
Huh?
Yeah.
And just the way this vessel has behaved, I am tending to go for a 2-stent.
Tap technique now.
Yeah, either.
No. See the last picture, that how much the diagonal is covered by the stent.
Is yeah,
No, it is
maybe
fully covered.
Yeah, maybe
Tap.
3-4 millimeters.
Yeah, that's good.
You want to do a tap then?
Yeah, that's fine. So let's get a 2.515.
No, let's take a caudal picture. If the left main looks good, maybe we leave it alone.
Okay.
Because we don't want another circuit disaster,
Yeah.
right?
Good. Okay. Now, if we need to be, then this will be the intentional protrusion of the diagonal stent into the main vessel with the 2 millimeter. Okay. Let's take a picture.
What should be the length?
No, I think we just go with the 15 or 25, 15 or maybe 18.
Huge.
18?
Maybe even shorter.
Or 15 will be okay.
15 is
We have
good.
15 should
15.
be.
Give us the 15 now. Good. Yes. Yep.
Now, what balloon you want in the LED?
We have
We
the
put
very
that
many
2.5.
balloons. We have many balloons.
You don't pull anything. Wait.
Yeah.
Let me do it. Very good.
No, 3O. Any
Okay,
3O will be
good,
okay.
Good
Yep.
news is the LED looks very good.
Yes. Yep. And the same thing that, as I said, that in acute situation, your goal should be just concentrate on the main vessel and you'll get enough time to work on the side branch later. Once we start working on the side branch and you start making the clot dissection all throughout, that will be the problem. Okay?
Anu, in your mind, I can sense that you are still trying to figure out what to do with the left main, no?
Yeah. Now, I'm just thinking if in the caudal picture things look
Yeah,
good,
exactly.
maybe we should leave her alone.
And maybe bring her back, they're not unusual. These cases you bring back in 3-4 months to see how things are. Good.
The double wire with this glide is hold on,
Finally.
you let go. Okay, hold it now, hold it.
Okay.
Now I hope this DAG stent goes in. She's requiring a pacemaker.
Yeah, which is all right, because the medicine have been given.
Should we use the guideliner again?
No, but I think we need to dilate the ostium of the diagonal maybe once again with the high pressure, because that was the low pressure. We are 2.5 of our high pressure balloons. Huh? Yeah. Yep. Good.
She's very restless.
Yeah, we are quantum apex.
Hmm?
Yeah, we are dilate the ostium. That's
Okay.
okay. Wire is all right. No, take it out. Take it out. Yeah. Now, basically, what also has been shown in the literature that once you are going through the stent struts, that make sure you have the non-compliant balloon, or you may be compliant also, but go to minimum 16 atmosphere. So that many times, it's not uncommon, they dilate 8, 12 atmosphere, and now wire coming back. Wire coming back.
It's sticking. I know, I saw that.
Yeah.
It was sticking bad.
Yeah. That start developing that you need a high pressure, at least 16 atmosphere. I prefer usually 18, but 16 to 18 atmosphere. Need balloon support again? We can give you another balloon support. No, I think we need balloon support again. Get that set.
No.
Huh?
Let me just
The same thing that the both wires sometimes get crisscrossed and then try to take it out. The pull back, even if you are very careful. See the eye? I think it's going into the same time to time into the same channel. And wire tip. Now we need to.
Okay.
Okay. Let's go with the high pressure. Yep.
Why don't we
Okay,
put a run through in the LED so at least one becomes. Huh?
Okay.
What is he saying?
Okay. Yeah. The radial announcement today. Hold on. You want to put a run through in that lady? Right now you have the OK wire.
It keeps coming back. The other one.
Good.
Get the guideliner.
Okay. I think after a long time, the real challenge
Let's use a guideliner.
No, but why? Balloon is will go in.
Good. It's not going to go.
We dilate here. No, the high pressure, we didn't open earlier. 18 atmosphere. Huh? Yeah. Yeah. The now question is good.
Okay.
Yeah, it will go now. The stent will go. Yep.
You know, this is what I had observed as you were pulling the IVUS. There looked to be fair amount of calcification right at the ostium tip there, which is where I think you just dilated.
Yeah.
I think our bursa should have been 175.
Right.
I think if we had to say that
Because of the long lead.
You mentioned, I think that's the real teaching case of this this entire.
Use the guideliner.
You know, one goes through something like this. Initially, I was
then
even
you
questioning
cannot put
myself,
it.
could you
No.
even do this without rotational ablation and maybe go high pressure and...
Yeah. I think one important that actually has just been keep coming back because of that area which we could not dilate, recurrent dilatation, multiple dilatation, and the Anu wanted to use the guideliner. I think we can do if it does not go, but this one we go because I was very confident the way balloon moved.
Okay, give me a balloon now.
Yeah. Then
So
we
this
can-
we are going to demonstrate how we are going to do. This would be whatever you can call. We are going to tap technique, you know, the reverse T balloon, 2-5 balloon. Any 2-5 balloons we
or
have?
3-0, whichever one
3-0.
have,
No,
right?
2-5 better.
Yeah. Good. Yeah. But you can dilate if you want to put the stent first, because the stent will move otherwise.
This has to be in the main vessel first.
No, you're going
So
to-
we already place a stent in the side branch, and then we take any deflated balloon.
So this is
Between
to
2-5
precisely place the diagonal stent.
No,
This
no.
one is
This is
yeah.
the
That's the one.
intentional
That is
protrusion.
one. The second is that clearly it's angulated, so that you will not regular one will not work. Here you want the stent to come a little bit into the main vessel, and you see here. Yeah.
Okay, you want to go caudal so that we are not hitting into the...
Okay. That
So you
base-
have
Your fault.
2 millimeters of the stent.
Yeah.
No. Can you move this down?
Camera a little down. Good.
More.
Yeah.
That's a beautiful picture.
Okay, so now we just have to make sure exactly.
Take one picture.
Yeah.
Yeah. Let's take a cine here, because this will be the T technique with intentional protrusion of the side branch into the main vessel.
Too much protrusion.
Yeah. No, but that's okay. Your full coverage here,
Pull back.
and you're going to make it a single lumen. That's fine. That's okay. It's okay.
To me, even a more relevant observation is the circumflex looks all right.
Yeah.
Yeah.
That's good. Okay.
I went in a little bit.
Good.
Okay, now good.
Good. Okay.
Okay, go
Huh?
with the with the
The
side
stent
branch
first. No, stent first. You deploy the stent. Yeah. Deploy the stent.
12. Good.
12.
Okay.
Yeah. Good. Negative. Go up again. Good. Negative. Now we are going to pull back 2 millimeter, both of them, and then create just single layer carina. You know, SKS would have been a 2 layer. Yeah, go up here.
Wait, I haven't pulled the.
Everything came out.
No, my LED.
Good. Now you bring the side branch also.
Okay.
Okay.
Yeah.
Okay.
Yep.
So the balloon in the LED has made sure that the lumen is okay, down.
Yeah.
Your
LED you need to
slipped.
bring more back. Yeah.
Don't go too high.
Yeah. No,
Take-
moderate pressure.
Techniques for carina management.
So now what happens, you have a single layer carina of the diagonal stent in the LED. So this final kiss is going to make sure that carina will be okay.
And it's a single layer carina. Now, prospectively, you wanted to go with the 2 stents approach, which is our simultaneous kissing stent. That create a double layer carina. Okay.
Okay, now let's take a picture and see if it's good.
Cine or just fluoro?
Cine.
Guide a little more.
Beautiful.
Looks just fine. Samin, your call today. My feeling is we have demonstrated just about every teaching point there needs to be. Do you want to continue or?
Bag distally looks bad.
Yeah. Okay. Now, basically, no, I think we'll see that if this looks good, otherwise also we could just leave everything alone for the time being and decide anything in the future. This patient has a lot of distal diagonal disease.
Leave it alone.
See that can be left alone. The tap technique with the LED diagonal bifurcation.
Look at the left knee.
Yeah. And then there is a mild distal left main still there. The question is that do we take care of that now or do it later? That's the only issue remains.
My suggestion would be to take care of it now.
Yeah. Because the key is here that there is a little bit of, I think now we should take care of it at present. So leave one of the balloon. Let me just help her now. Let me do. This one will be kissing. Can't do anything.
SKS?
Yeah, now you cannot do anything else. Now what we do is one of the balloons.
We leave it alone.
Yeah, diagonal will coming out.
Just take
no,
out
one
everything.
balloon. No, one balloon. Okay, just 1 second. One is the high pressure.
One is a stent.
Yeah,
It's a high
take the
pressure.
stent. This is the stent,
Yes.
right?
Yeah.
Okay, that's the diagonal wire. Good, and stent. Good. Okay, go back to that caudal view, our aleo caudal. Good.
Now she has been on Plavix, and we checked her Plavix sensitivity. Actually, she's 83% inhibited on 75 milligram.
So you're perfectly happy with that?
Yeah.
Yeah.
I think for this age, 40
Yes.
we would be very happy. So there should be no problem with the double stent in the left main and double stent in the LED diagonal.
Okay. Now that we're trying to use the same wire. I think we may
Tip
need a
is
new
gone.
wire, right?
Yeah, tip is gone.
Yeah, good.
Okay,
Well done.
good.
Okay, that went in
Okay.
pretty easy.
Get the balloon. Yeah. That same balloon which we just had. High pressure balloon. Yeah. Okay. Now we go decide quickly so that we finish this case.
We put her 275.
Okay.
Yeah, I'm particularly pleased that you decided to address the left main. I
Yeah.
think with so much manipulation around it, I would feel very
Get us a
uncomfortable
275,
leaving,
23. You want a 275 to the LED? 30.
23 and 3 or 12.
Okay, 3 or 12. That won't kiss the...
Nope. 3 or 12. 275 and 30. Yeah, you're right. I mean, we had to do it now because these are the cases. Otherwise, we actually had a few months ago catastrophe same way. Went through the moderate left main and did not do anything. And few hours later,
Exactly.
Those closes. Actually, not few hours. Few minutes later, while on the table. Yeah.
I also think considering
stent
the elderly patient, that appears a little more appropriate strategy. Now this is a 275.
Now, this is a balloon. We're just pre-dilating.
Pre-dilating the...
Excellent. Yeah. The
So
ostium
we are
and the
going to do
proximal
a
cell.
275, 23 to the circ and then 3 or 12 to the LED.
Yeah, go up. And purpose is that plan was to do the left main intervention anyway. That was always because of the disease and confirmed on the I was negative. And this kind of case,
CC
now
bed.
knowing that she is very stable, her EKG has come down and the blood pressure is good. She's not moving. That means not having any chest pain. And now you are ready to put your additional 2 more stents. I mean, we thought that this will be the 4 stent case. Give me the 23 first. The first, you want to go through the difficult stent strategy first. Where, yeah, the way
That is always the side branch.
side branch.
For this would be the circ. But
Now
here
where-
we may have LED. We have been having difficulty in getting the stent into the LED.
Okay, yeah, maybe, yeah, let's hold. Now, the question also, which we learned that for the bifurcation, that it's the vessel size which they count as a main vessel. Your LED diagonal bifurcation, but your diagonal is bigger than LED. Okay. Yeah, if your diagonal is size-wise bigger than LED, so that is considered as a main vessel.
I want to show the guideliner at the end, how it looks.
Yeah, which is fine. So now the stent has gone into the circumflex. And now the challenge of the LED remains, and then knowing that's a little bit of stent in the proximal LED, but we should be connect this. Good.
Pull back the circ. And okay, you have
I think
the
you
LED.
have a sufficient overlap there
Yeah,
with
yeah,
the...
not yet.
No, not yet.
I'll tell you.
What are you doing?
Pulling back the circ.
Yeah, please. Vicky, you want to give little atropine also? 0.3. Circ has to come back.
I know. I'm just moving this and the circ. Okay. That hands off 1 second. Move the hand. We can take a picture. Yeah. Good. Take a picture. This is the key.
Good.
Good. Go both.
So we're going deploying at 8, both of us. Good. Sine.
Good.
Now is the same thing because we are going to do the distal left main. We already telling her give some neosynephrine, so the blood pressure goes up. I'm going up.
Negative.
So the blood pressure is 120.
Expand to 12 atmosphere.
Yeah, I'm at 12. That's the circ. It's a good expansion.
Is it 275?
Good.
Yep, 27523.
Okay.
Going up with the LED, 10, 12.
That's
Good.
the LED
Now-
also
Yeah.
at 12.
Yep. So now let it have a little breathing. But we got a little time ahead of the game, so that now go back again. Both at 10 atmosphere.
So you go.
That's your final step.
Yeah,
Yep.
yeah. I'm
And-
going to go actually 12 because the
Yeah.
circ needs a better
Little
expansion.
better expansion. Her hand has to be on the side, please.
Down.
Yep.
Yeah.
And simultaneous inflation and deflation, negative. Good. And you see
Now-
that my guide always remained outside.
She has a
and,
good, like blood pressure is 140, heart rate is in the 72 range.
And always I say that a very important issue that this final moment that if blood pressure even need to be increased for a few seconds, which is
Good,
okay.
we're done.
Yeah, that it's okay that you give a neosynephrine,
So that's
increase
your,
the pressure.
That's your pharmacological impeller.
That's it.
Yeah.
Just for a few seconds.
And whenever you're doing the left main, this pharmacological therapy is very important. What happened with this lady earlier when we were doing the LAD, when we gave neosynephrine, she started using the pacemaker. So what then you do, give very low dose of atropine, which was like 0.3, because neosynephrine reflects bradycardia, take care of with the atropine. Then you give neosynephrine, so your heart rate, blood pressure is well controlled before you do your deployment so that you can do the stent without worrying about hypotension. What happened to the guideline?
All right.
Just the superior portion of the circumflex in this view, but I think we had that very nicely covered otherwise.
Yeah. The same thing that it looks a little different in various views, and as long as it's a reasonable expansion,
Okay.
go to epicranial.
Post-dilatation. Sir, post-dilatation.
Maybe not. Later. Yep. And then this picture will decide what else we need to do, or we finish it here. One of the long case with the 4.
I think you are done.
Yep. Good. You want to just say about your?
So I just want to show the guideliner. This is how it looks. So this is to be used in the 6 French. And if you see here, they have 7 French also. Yeah. So it's very soft tip. So it remains like a wire inside the guide. So what it does, it guideliner means it extends the guide. So especially crucial in the situation like we saw here when we are not able to deliver the stent to the mid to distal area. It's like extending the guide from the left main to the proximal LAD, or in the RCA you can go all the way up to mid RCA, especially helpful when you have very tortuous RCA and when you are doing total occlusion, when nothing is going to go, you can have this support.
Some of these cases, as we noticed here, once you have the guideliner in place and you have the support, would you sometimes pull back the guiding catheter slightly?
You may have to pull the guiding catheter out, but other thing that we notice, despite especially if you have, even if you have side holes, now this is going to cover the side holes, and since it's extending all the way to the mid to distal portion of any kind of the vessel, you will have damped pressure.
Samin, this has been, Anu, sorry to interrupt your last point there. I'll let you actually state that in your, I think this has been a long case, and I would request both you to give me some individual take-home messages here.
Yep. I mean, I think basically the change from what we have already would be the difficult case, but your strategy, keep persistence as long as you are paying the guide wire, issues with the postal dissection. Yeah, there is a issue in terms of the technique is the same, but the change strategy when you encounter the problem. And clearly, even we didn't start at the one stent technique, we did a two stent in this particular case, but was very, very helpful. And we can take the last one, last slide from that purpose, and will be just end of it. And that is that support in this case would have been a little better, but since LV was okay, we didn't use any support in this case. Two stent technique, I think this was a little unstable patient, so we did not use the DK crush. Hopefully we'll be able to show that in some time in the future, and continue incorporating syntax score in the real practice.
Anu, please continue your thoughts also where I had stopped you off on the guideliner.
Yeah, the guide. No, I think in the situation where tough situation where we need to use a guideliner, and you know we cannot use you cannot see the pressure. As long as we know there is a flow in the vessel, and have your strategies correct so that you are able to deliver your stent distally, do a quick job, and then come out even if there is no pressure. And you just going back to the two questions that were asked earlier, that that this patient should have been left alone. She lives alone, takes care of herself, goes outside, does shopping. In this kind of situation, it's very difficult when the patient has been managed medically. That LAD has been managed medically for many years until she came with the acute MI, the non-QMI of our RCA, and we found that now there is disease and has been disabled on medical therapy, and the private cardiologist is still outside in the control room saying that something had to be done to this particular patient. So medical management has always been tried, and only when it fails at this age, we know, then we offer percutaneous, since bypass would not be an option for this particular age. And the key to the success, like all the numbers shown by Dr. Sharma, that yes, the credit goes to the attendings and the staff of the lab, but the pillars for this success for me would be our interventional fellows. We have two here today, Sham, who has joined us from downstate, and we have Sumit Tikku, who has been here for 6 months, and in 6 months they are capable of doing moderate to complex PCIs all by themselves, and the protocol and rigorous training of these fellows will help us when they are doing cases with our other attendings to do the protocol guided PCIs.
And the afferent issue remains that rarely over 75 we can give 5 milligram, but in this particular case we knew inhibition was good, but rare cases even more than 75 and even CVA. If your clopidogrel is not working, then prasugrel is reasonable choice, and I have a few handful of patients giving a 5 milligram daily or every other day in those situations. With that note, I know it was a long, tough case, but hopefully a lot of technical points, excellent results in the end, and will be very useful for all our viewers, and will be archived shortly.
Samin, I think the patient has been well served. I personally know Dr. William Schwartz, an extremely outstanding, competent, very bright physician. He'll be very happy. Thank you for taking us through this long case. To me, the lesson is exactly how we started today. You presented some data from New York State, and we talked about how do you keep complications low. That is exactly what I think we have shown in this case. Humbling case started something which would have been fairly straightforward, but excellent modification of the approach, and thank you all for showing this case. Congratulations to your entire team. Please continue following us on Twitter, and we will see you for the next transmission, which is on March 15. Thank you.